Good morning and welcome. My name is Jade Purdue-Pulley, and I serve as the Assistant Director for Patient and Workforce Safety at the White House Office of Science and Technology Policy. Thank you so much for joining us today, both in the room and via webinar, for the White House Healthcare Safety Forum on World Patient Safety Day. It is okay to clap. Thank you. To begin our program, it is my pleasure to introduce you to Dr. Arthi Prabhakar, Assistant to the President for Science and Technology, Director of the White House Office of Science and Technology Policy. Dr. Prabhakar.
Thank you so much. We're so excited to have you on board to come do all of this work. This is fantastic. Welcome to the White House, everyone. We are absolutely delighted to have you here. Let's start with a really sobering fact. Here we are in the wealthiest nation in the world, and yet our health outcomes in America lag behind dozens of other countries. Really an unacceptable fact. And today, what you're going to be focusing on is one aspect of that problem, and that is the issues of patient safety. This is a topic that our President's Council of Advisors on Science and Technology, which I have the great privilege of co-chairing, PCAST dug in on this topic. Eric Horvitz and Joe Chiani are here today. Thank you all for the work. And they laid out the issues, at the end of the day, the story here is that too many unacceptable errors are committed during healthcare that are preventable. There are things we can do about it. There's work that we have to get after here. And that PCAST report laid out the problems, talked about, made some very important recommendations. And when we met with the president and discussed this topic, he was just completely clear that we've got to get after it and that there's work to be done here. He said finding and implementing solutions to reducing medical errors is going to improve health outcomes and protect our loved ones. That's what it's all about. That's what we are here to focus on. And you all know what the issues are. I think when people hear the term a medical error, maybe the first thing that comes to mind is it's a complex surgery and there's a mistake that gets made in the heat of the moment. That happens. But of course, sometimes it starts off with things that seem quite mundane. So it could be that a patient's weight gets recorded incorrectly, and so the dosage of medicine that they get is off. Or it could be that there's an incomplete medical history, and the new drug that the patient takes interacts with a drug that people didn't know that patient was already on. It could be as simple as the fact that a patient's not able to change their position in their hospital bed, and that leads to bed sores, and of course then from there to infections. And these examples, none of them, the dramatic ones or the seemingly mundane ones, none of these are secrets. We talked to a lot of very serious experts about these topics. This morning, in preparation for talking to you all, I called my daughter, who is a Grey's Anatomy fanatic, and what she told me is she's not in medicine, but I told her these examples, and she said, virtually every one of those was the subject of a Grey's Anatomy episode. So it's not news, right? It's not a secret. Then you have to say, look, what is going on? Because what we know is that nurses and doctors and other health workers, these are people who chose these lines of work, for many of them it's a calling to serve people and to heal people. So what is going on here? And what happens is when you start peeling the onion and you try to figure out what is going on, what you find is that so many of our healthcare workers are working very long hours, losing sleep. Often they are dealing with their own trauma from what they experience in the line of work that they have chosen. Some of them are on the receiving end of threats and even physical attacks. And so, really when you look at that, it's really no wonder that many of them are experiencing burnout. So, think about the hurdles that these people are trying to overcome to be able to do the work that they've really chosen to do. So look, the bottom line is that errors that lead to patient safety issues, many, many, many of them are preventable. We know what it takes to solve these problems, and we have got to get after it. And so this forum, I was so pleased to see all of you come together, because this is a perfect way to really accelerate the efforts to address patient safety, to help our health workers do the work that they really come to work every day to try to accomplish. And it's a perfect way to mark World Patient Safety Day. So thank you all very much for being here, and let me turn it back over to Jade. Thank you.
Thank you, Dr. Prabhakar. Our next speaker is Dr. Charity Watkins. Dr. Watkins is a Birch Scholar and Assistant Professor in the Department of Obstetrics and Gynecology at Duke University and the Department of Social Work at North Carolina Central University. Dr. Watkins will be sharing her experience as a person seeking care within the healthcare delivery system. I'd like to ask for a special kind of listening for all of our healthcare clinicians to listen with the intent of identifying the missed opportunities. Dr. Watkins.
Good morning, everyone. Let's try that again. I'm an HBCU professor. Good morning, everyone. My name is Dr. Charity Watkins, and I stand before you today, as Jade has already shared, as a 3-time graduate of the University of North Carolina at Chapel Hill, Assistant Professor of Social Work at North Carolina Central University, maternal health researcher at Duke University, and the Board of Directors Chair of Equity Before Birth, a community-rooted nonprofit birth equity organization based in Durham. But just 9 years ago, I was Charity, a 30-year-old Black woman in graduate school, attending birth classes and prenatal appointments, reading What to Expect books, and joining online support groups, preparing to welcome my first child into the world. But nothing prepared me for what would happen. After giving birth to my daughter via an unplanned cesarean delivery, I experienced my first medical harm. With encouragement from the labor and delivery team, I began walking around my hospital room just one day after my C-section. That is until I heard a sound that still rings in my ears today. The sound of my blood splattering on the tile floor. In response to my husband hysterically requesting that a doctor examine me, a physician with my sister-in-law in the room holding my newborn baby and my husband holding my hand, manually removed clots from my uterus twice. I was provided no warning and no medication to counter that unspeakable pain I endured. Can you imagine the fear my family experienced? Can you imagine the trauma I experienced? Well, if you can't quite yet, let me paint an even clearer picture for you. Imagine going from walking 5 miles during your pregnancy to not being able to walk up one flight of stairs without needing a break to catch your breath. Imagine not being able to sleep comfortably because you can't lay flat without feeling like you are choking. Imagine being so tired that your partner thought you were going to drop your infant before making it up the stairs. Imagine making an appointment with your OB only to experience your second medical harm, as you're told that you are probably experiencing symptoms of the flu. Probably. Imagine your symptoms getting worse. You now can't make it up a half flight of stairs before feeling exhausted. You now have lost your appetite and experience nausea with every diaper change. When you attend yet another appointment with your OB, you're now told it's probably postpartum depression. Probably. Despite being trained in mental health, your fear of being viewed as a difficult, non-compliant patient makes you follow through with counseling. But your physical symptoms persist. And within a week of returning to work from maternity leave, You experience a throbbing pain in your left arm that radiates up through your neck and jaw. It goes away soon after, so you dismiss it as a muscle spasm. But just 2 days later, it happens again, but the pain is more intense and lasts longer. Well, aware of the symptoms of a heart attack, you make the hard decision to leave your infant at home and go to the emergency room. But instead of receiving care there, you experience your third medical harm as you wait 5.5 hours in the ED waiting room, never to be seen by a doctor. It wasn't until I went to student health a few days later that my symptoms were heard, listened to, and I was examined. My condition was serious enough for the student health doctor to have me rolled in a wheelchair back to the same ED. But yet, I waited there in that same waiting room again for hours before being brought back to a room. Medical harm number 4. I was later admitted into the cardiac intensive care unit with an enlarged heart that was functioning at only around 5 to 10%, with a diagnosis of peripartum cardiomyopathy, or pregnancy-related heart failure. That meant no more children for me. That meant regular cardiology appointments as a 30-year-old woman and a lifelong heart medication regimen. But it also meant that I was still here for my daughter, my family, my community, and to advocate for other birthing persons of color to not have the same patient experience as I did. So as I stand here today, by the grace of God, on World Patient Safety Day, encouraged by the Biden-Harris administration's commitment to changing near misses to never events through meaningful engagement of patients, families, communities, clinicians, researchers, organizations, and agencies as outlined in the 2023 PCAST report. I am motivated by my social work profession code of ethics that we bring to multidisciplinary teams like the National Patient Safety Team established under President Biden. I'm energized by organizations like Patients for Patient Safety US that lead efforts to promote health equity strategies based on patient experiences and recommendations. I'm inspired by community-rooted work of Joy Spencer and the Equity Before Birth team, who shows us how the intentional centering of patients' voices in healthcare can interrupt long-standing inequities to contribute to multi-generational well-being. I stand with my fellow patients, survivors, birthing persons of color, and change agents. We deserve better, we can, and will do better. Thank you.
Thank you, Dr. Watkins, for sharing your experiences with us. It does serve as an important reminder of why we're gathering here today in honor of World Patient Safety Day, to honor and remember those people who have been harmed and those who have tragically passed while seeking health care, and to act our way into a better, safer healthcare delivery system, one that provides safe care everywhere and zero preventable harm for all. Next, I'm pleased to invite Dr. Danielle Carnival and our special guest of panelists to the stage. Dr. Carnival is the Deputy Assistant to the President for the Cancer Moonshot and Deputy Director for Health Outcomes in the Office of Science and Technology Policy. Dr. Carnival.
Thank you, Jade. Hello? Yes. That's the answer. Well, thank you, Jade. First of all, thank you, Doctor, for sharing your personal story. I don't think we need to spend additional time here talking about the reason we're all here or admiring the problem, but I think what I'm excited about is that I have a panel of leaders across the Biden-Harris administration, who I'll introduce in just a moment, who are really focused on providing support and care to those at the center of our healthcare system. And when we say that, we mean both healthcare providers and patients, because there's a partnership here and protections that need to, and a system that needs to be in place to improve for both, to get the outcomes that we want for patients. So we have Dr. Bob Otto Valdez, who is the director at the Agency for Healthcare Research and Quality at the U.S. Department of Health and Human Services. Bob, welcome. We have Dr. Sharif Elnahal, Undersecretary for Health at the U.S. Department of Veterans Affairs, and retired Rear Admiral Ortega, Deputy Assistant Secretary of Defense for Health Services Policy and Oversight, Office of the Assistant Secretary of Defense for Health Affairs at the Department of Defense. So I don't want to delay the discussion further. I want to start, Bob, with you, Dr. Valdez. AHRQ, as the lead HHS agency for safety, you launched the National Action Alliance for Patient and Workforce Safety. Tell the crowd today a little bit more about what the goals are there and the work that you're excited that that alliance is taking on.
Thanks very much, and thank you for joining us this morning. The National Action Alliance is really a collective effort of patient safety advocates, healthcare executives, healthcare clinicians who day in and day out are at the front line, and researchers and others who are engaged in trying to make healthcare safe for all. Together, we really have tried to bring evidence-based safety strategies and lessons learned from near misses, from other events, to actually make healthcare better for everyone. The National Action Alliance is the result of conversations that Secretary Becerra had with patient safety advocates and healthcare leaders at the height of the pandemic, when the safety indicators were actually going in the wrong direction. And quite honestly, it's been an issue that was even present before the pandemic, but the pandemic made it visible for all to see. And after those discussions, he charged AHRQ with coordinating a departmental-wide initiative to move patient safety back to where it needs to be, which is safe for all. During the course of the pandemic and even after post-pandemic, we've been losing the trust of the American people in American healthcare. And so dealing with this issue is critical, not only to regain the trust of the American public, but also to save the lives of our family members. Secretary Becerra then asked us to move forward with this, and thanks to the PCAST recommendations and the work of the National Advisory Committee of AHRQ, which is also advisory to the Secretary, we were able to move this agenda forward to partner with other federal agencies, with all of the department's resources, to really push on this really difficult rock that needs to be pushed up the hill, because there's a lot of inertia both in the system and elsewhere. As a result of the PCAST recommendations, we were able to put in place a number of different aims that I think changed the ballgame. Part of it was recognizing that we needed to set a goal, and an audacious goal. We put a goal of 50% reduction in harms by 2026. So we've got another year to reach out and actually meet this goal. And we're making real progress. The National Action Coalition is really implementing the National Action Plan for patient safety in a way that hasn't happened in previous efforts. And it's largely because of this collective effort that many of you in the audience are helping drive. And so I want to thank you for your efforts, and to thank those of you who are watching us online who are also at the front line and helping us move this agenda forward, because healthcare is not safe until it's safe for everyone.
Thank you so much. I want to build on that and turn to Dr. Elnahal. I know you believe what President Biden believes, that we have one sacred obligation as a country, which is to take care of our veterans. and you run a somewhat large healthcare system at the VA. Please tell us how you're thinking about this and what steps the VA has taken as part of the Alliance and beyond.
Well, thanks so much, Danielle. This is such important work, and I do want to add another note of thanks to Dr. Watkins for your courage in sharing that story. If somebody on a career pathway to being a university professor and a clinician can be treated this way in our healthcare system, it just means we have a lot of work to do. And your story really brought home that behind every single one of these statistics of preventable harm is a person who deserves better, from our healthcare system writ large. And I would certainly say the same of our 9 million enrolled veterans across 172 medical centers that we serve across the country. Patient safety has been a priority for the VA since the mid-90s when the discipline was really just forming. Our National Center for Patient Safety has been leading the work on this effort nationally since then, but I can't tell you how valuable the National Action Alliance and the work that ARC is leading has been, and we've been really important and meaningful contributors on that. The most important thing we can do is to garner and gain the voice of the patient and gain the trust of the patient in our processes to improve outcomes. And so we embarked on our effort on high reliability starting about 5.5 years ago, which is really a culture and a movement in healthcare, not just a discipline, that is instilling the principle of zero harm in everybody in our healthcare system, not just our clinicians, but our extremely important support staff, frontline workers of all types, and yes, our leaders and managers who have to learn that it is just part of their job to not react negatively to when a frontline worker or a scrub nurse in the OR or an environmental service worker who's cleaning patient rooms and identifies a vulnerability. That person needs to be listened to and rewarded and incentivized to report. And so as a result, in many cases of our work with the National Action Alliance, we've been able to increase our submitted patient safety reports significantly. We use the same patient safety reporting system as our colleagues in DOD. And you might say, well, doesn't that mean more safety issues are coming up? Isn't that a bad thing? Well, folks in this discipline know that's absolutely not what it is. In fact, you have a psychologically safe environment, you expect to see more reports because these things are happening, and they're happening across our healthcare systems in this country at much higher rates than we are detecting them. But one encouraging piece of data is that our ratio of near misses or reports that haven't hit the patient over our incidents that have hit the patient or affected the patient has gone up, meaning we're getting a lot more reports. A greater share of those reports are vulnerabilities that haven't yet harmed patients, and that's exactly what you want to see. And just year over year, we're starting to see, for the first time since the pandemic, significant improvements in our quality and patient safety outcomes, including 58% of our medical centers scoring 4 or 5 stars on CMS's overall hospital quality star rating, compared to only about 40% of private sector hospitals. So we're really proud of those results. We're most proud, thank you. We're most proud of our patient experience and trust scores, which are now at 92% of veterans telling us that they trust us for their care. This is all because of our investment in patient safety, and we hope to continue that really important work. Thank you.
We're going to go over to the DoD side. Retired Rear Admiral Ortega. Again, the essential to DoD's mission, as we all know, is the health and readiness of our service members, and protecting them from these harms is really important to the DoD. Can you tell us a little bit about how you all have stepped up and changed practices and behavior and outcomes here?
Great. No, thank you, Danielle. And first of all, even before I start, I want to acknowledge Charity. Thank you for really sharing that story. It's really, I think, for all of us, it's a grounding moment. We've got to, in this important event, really to galvanize us all together, because I often say, you know, if not now, then when? And if not who, then, if not us in the room, then who? And so leaning in to sort of break all of these barriers between the government and the non-government sectors is just an important point in our time of really transforming and bringing healthcare delivery and health patient safety really in tandem. Thank you very much. As we look, of course, in the Department of Defense, we took these initiatives really seriously. The first one wrapped around our leaders. I mean, certainly Secretary Austin and Dr. Martinez, my boss, looked at really unpacking our military health system in a way that, because it touches so many of our really our servicemen and their beneficiaries, 9.5 million. We've got certainly 45 hospitals, over 100, really over 100 clinics that are dental clinics, and then you wrap that around and look at over 500 outpatient centers. So you can really see how that's peppered across, really across the world. So we've got a big responsibility. But the good news of this is that we've really been underway both from examining and expanding our policies to look at patient safety. We're really pleased because we embarked on our military health system, and one of our major missions behind that is ensuring we have patient safety and changing the narrative, as my colleagues mentioned, both from the clinical front and also the patient safety front, and making sure that they can bring forward those challenges they have or concerns they have around their safety. We're really pleased that our Defense Health Agency, which is the operational arm, the engine who's responsible for executing all of those clinics and dental clinics, facilities, hospitals across the world under Health Affairs, they've been embarking on really all of many measures. I'd like to actually speak to a couple. One is certainly the Leapfrog, as you probably all know, the hospital safety grade program. So we're really excited because as of this year, we have 43% of our outpatient, our military treatment facilities that received an A grade, and that's good news for us because that exceeds the 30% that's on the national average. And then certainly our hospitals, 86% of them are receiving an A or B grade. So we're really driving forward and focusing on that commitment. We've been really fortunate to expand our tools and taking that commitment on the electronic record-keeping side. And as my VA colleague pointed out, certainly with that joint patient safety reporting mechanism that we have underway, now we have more barcoding. And in fact, in the summer, our MTFs barcoded about 95% of all the 2 million inpatient medications. These are small steps, but really powerful impacts. And then finally, I would just say in the context of sort of one team, one fight, really bridging and ensuring that we cross all of the departments that have the same focuses around patient safety and leveraging the surveys that are out there that exist, certainly with ARC surveys around changing that culture narrative for patient safety. Just a few steps along the way, but we're really enthusiastic. We've certainly got a long way to go, but we've taken those big strides.
That's great. I want to follow up on that last point and ask Rear Admiral Arcega to say a little bit more. We've started off this conversation in silos a little bit as to what the agencies are doing, departments and agencies are doing separately, but can you tell us a little bit more about what you've learned from one another or how that has really progressed the work that you've been able to work across and learn?
Absolutely. Obviously, naturally, the Department of Defense has a lot of collaborations with the Veterans Health Administration and the Veterans Business Administration, the two, not to steal your organizational thunder, but under the VA and with the Department of Defense, I think we've had some, I'll say just partnerships that have formed, I'll say phone a friend, but now there's more really collaborative and I'll say committed partnerships. So what that means is sort of ensuring we have what was called these joint executive committees, which really ensures both parties come together, kind of keeping each other accountable for, in that transparency for work groups and initiatives that we have committed. That's one, and then certainly the other, I would call out that we have what are called clinical practice guidelines. Both the Department of Defense and the VA sort of going from a one sheet of clinical practice guidelines to deliver that care. And what does that do? That really ensures, one, that we're committing ourselves to ensure those highest patient standards, and then also the safety reporting standards.
Thank you for that. Dr. Allenhall, coming back to you, are there specific things that you and the department gained from the PCAST report that you're now implementing, and what does, there were some really positive signs of progress, what does the future look like for Veterans Health?
Yeah, absolutely, and I think really important recommendations came from that. A lot of it is focused on how do you not only discover the right framework, programs, practices to lead to safer environments and preventable harm, how do you scale them, and then how do you involve the patient more meaningfully? And so we are essentially setting up a system that allows us to lift up the medical centers with the highest scores on our HRO dashboard, which is a number of patient safety outcomes, patient safety indicators, et cetera, but a lot of really important leading indicators too. Are people using the Just Culture framework that we have to understand and really reflect that understanding in real time that the vast majority of patient safety incidents are systemic issues, issues with processes, issues with our policies, which perhaps don't interface well with the patient safety mission, versus individual accountability and harm. But there are issues that ultimately do require you to hold individuals accountable when there's malfeasance, negligence, folks that otherwise don't operate, fail to learn what our system is. And so we have ways of racking and stacking who's doing the best, and then now leveraging our network-based way that we organized ourselves in the VA, are going to be holding the entire system accountable for implementing those best practices. On the point of involving the patient, we've got patient advocacy committees already at most of our medical centers, if not all of them. We need to make sure that our patient safety agenda is not just rubber stamped and run by our patient committees, but we've got co-design and meaningful involvement of our patients. Dr. Watkins' story just gave me a lot of encouragement that we need to make sure we involve the voice of the patient if we have any hope of actually meeting their needs holistically. And it first starts by listening to the patient and being attentive to the patient and not substituting our biases and our sense that we provide awesome health care overriding what's ultimately happening with the patient. And so a lot of these things are underway, but a lot of important work ahead.
Dr. Valdez, to come back to you, you mentioned the kind of learnings or the impact of the pandemic, like so many things in our public health and healthcare systems. The pandemic laid bare some of the issues that we needed to address. I know HHS reported increased patient safety events that erased decades of slow but really meaningful progress. How are we today, and kind of what have we done to hopefully you're going to tell me we're back on solid ground, but what does that impact look like, and how have we come out of that over the last few years?
Well, I think you've just heard from some of my colleagues in the Defense Department and in the VA that really there's some culture change going on. And at the root of the National Action Plan for Patient Safety is a recognition that there has to be an adoption of an innovation, safe, orientated culture in our care delivery systems. We have varied care delivery systems in our nation. We don't have a healthcare system. Not everybody operates one arrangement like in the VA, but we have many, many healthcare systems that are operated and regulated by the states. And as a result, we've had to be very flexible. We've had to be very astute in bringing everyone together, because it really does take this collective effort. But most importantly, it takes the voice of the patient to drive quality improvement and to make care safe. And that's one of the lessons from the PCAS that I think I think everybody's recognized was an important message to put forward. As a result, many of our partners, private partners who have been looking at how we've been doing with the National Action Alliance, moving this agenda forward, have illustrated, Leapfrog has illustrated in its most recent report that about 85% of hospitals have in fact made some progress on their safety events, particularly healthcare-related infections. More recently, the American Hospital Association, another member of the National Action Alliance, has also recently illustrated that we're getting near pre-pandemic levels in some of our safety events. That's not to say that's great, because pre-pandemic, we still had more than 1 in 4 people who walked into a healthcare system who had something go wrong, or nearly wrong. But I was really happy to see that earlier this week, I guess it was yesterday or Sunday, the New England Journal of Medicine Catalyst report reported on a survey of healthcare leaders around the country that really illustrated that the lessons to be learned are being shared. The recognition that there is a crisis in American healthcare and that we can't sit back has been accepted and is no longer just looking at, now, we all provide great care. And in fact, when you ask, I've been talking to healthcare executives and clinicians responsible for quality around the country for the last year. When you ask them, how's the quality of the care in your hospital? I say, well, great, excellent. And then when you ask the question, well, where would you send your mother for care? You get a quite different answer. And so most of us are trying to recognize that we want the care in our own facilities and in our own care that we would provide to our mothers or fathers and sisters. And more importantly, healthcare executives also recognized from a business perspective, providing high quality care is in the best interest of not only their bottom line, but also their communities. And so recognizing that in this world where we have a labor shortage, creating a culture of safety and innovation where continuous improvement and empowerment of all employees is really a selling point for finding people who want to work in your organization. And it adds to your bottom line and to the quality of your product. And quite honestly, healthcare trustees of institutions and organizations are now asking to see, what is it that we're producing? This is a first in our industry. For the vast majority of time, at least in my career over the last 35 years, 40 years, trustees and I'm a recovering, board of directors of a hospital system. Rarely did we see what the quality of our product, our service was as part of our agenda. Today, that's increasingly not the case. Increasingly, trustees are taking responsibility to look at the quality of the services and moving the agenda forward, because the culture of an organization begins at the top.
Dr. Valdez, as our time comes to a close, I want to give you a final word here. What should we be excited about seeing coming from the Alliance going forward that will help both the public and private sector healthcare systems really improve the quality of the care?
Well, as I said earlier on, this is a collective effort. So we'll continue to see great learning. I'm expecting that we will reach our goal of 50% reduction by 2026, in large part because of all the work that you're doing, those of you who are online and those of you who are in the building. But more importantly, a recognition, as was said by my colleagues, that this is not a point failure issue. This is a systems issue, and that we will come up with and see evidence-based strategies for fixing those kinds of structural and organizational issues that we know how to fix.
Dr. Elnahal, Rear Admiral Ortega, is there anything that you have to add to that before we close out? Anything that's coming that we didn't talk about that you really want to make sure everyone knows?
Just quickly from our end, we've got a lot of work to do on the innovation front when it comes to patient safety, bringing in the frontiers of technology to really get a pulse for the safety culture, but also in real time, how our practice is actually manifesting for patients. But I think in order for us to leverage that, we do have to build our bench of experts and leaders in quality and patient safety. And so our chief residency in quality and patient safety, now going on for many years, takes folks who want to build their careers off of this. And thinking about Louis Pasteur's really famous statement, "Chance favors the prepared mind," these are the folks who are going to help us investigate the next frontier in patient safety to meet and exceed the ambitious goal by 2026 of reducing preventable harm by 50%.
And I would just add, really unconventional partnerships, in my view, will be the turnkey moment. We have a lot more, as I mentioned earlier, work to do on this front around healthcare, patient safety. If you think of the Department of Defense, we have an additional challenge that exists for all of us, which is ensuring that that level is maintained in the battlefield. We're really excited, still have a lot more work to do, but we're really excited that now we have a council that brings together, first of its kind, a healthcare quality care council that brings everyone together outside this, outside of our Department of Defense, but also all of the services have representatives. And so we have that kind of think tank approach, but it will take those types of partnerships that are unconventional, leveraging all of the minds that you have. And I would just finally say, as you are thinking about the innovations that you are equipping, for those of you who are in hospital systems or even in organizations, think about the active duty, their family, and the veteran, because those technology requirements will allow us, again, to kind of integrate at faster ways than we often think. But the return on that investment is just paramount. So thanks.
Well, thank you to the panel here. I know there's lots more to get to. I just want to say I'm really heartened to see the commitment and the action from leaders across the Biden-Harris administration. I hope that having this event and showing how committed the Biden-Harris administration is to making a difference here really starts to reflect the voices from patients and families and healthcare providers that have for so long looked for a platform to really be heard. So thank you. Jade, back to you.
Thank you, Dr. Carnival, retired Rear Admiral Ortega, Dr. Elnahal, and Dr. Valdez. Very grateful for you being here today, and in particular for leading the coordination and collaboration of healthcare safety work across our government. Now, I'm pleased to invite Dr. Marcus Schabacker, Chief Executive Officer of ECRI, to the stage, along with his first set of experts from Cincinnati Children's. In this segment, we will spotlight some of the incredible, encouraging safety work occurring in healthcare systems for patients, the healthcare workforce, and their communities. Dr. Schabacker?
Thank you, Jade. My name is Dr. Marcus Schabacker. I'm the CEO and President of ECRI. At ECRI, our mission is to advance evidence-based and effective healthcare. And we believe in a world where safe, effective, equal care is possible for everyone. And I'm here today with my panelists. We're going to have 3 sets of panelists to talk about something that has actually worked. And to be honest with you, and Dr. Watkins, I can't thank you enough for bringing this to life for us. As a physician, I've sworn an oath. I've sworn an oath to do no harm. But still, every single day in this country, and actually around the world, we do harm. I have done harm myself. Not intentionally, of course, but it's a catastrophic event. First and foremost, of course, for the patient, their families, but also for the caregivers who are involved. And 25 years have passed since to err is human. But still, every fourth patient who is admitted to our hospital in the United States gets hurt. We have to do better. We must do better. Hope is not what is going to get us there. And I think there's a pivotal moment. We have a lot of momentum here. There's people in this room, there's people on the internet who are listening to us, who are in the position to make those changes. But it won't happen if we don't start. And that's what we really want to talk about here. And I'm so happy to have these 3 institutions who really made the difference for their patients. And we're going to start with the first one. We're talking on, and you heard it in the previous panel, and thank you for saying that out so clear, is we need systematic change. And I think that's what you have done. And we're starting with one which was also mentioned already, but which is most critical, I think, is that we need to engage the patients and their caregivers in a very, very different way, to be part of the solution and not still often seen as being the problem. So our 2 first panelists are from the Cincinnati Children's Hospital and have seen remarkable success in exactly doing that. And let me just talk quickly about the Cincinnati Children's Hospital, which ranks #1 in the nation in the US News and World Report from 2023-24 list of best children's hospitals, and is recognized as one of America's most innovative companies by Fortune. Was established in 1883, so it's been around for a while, and is a non-for-profit academic health system that is internationally recognized for improving child health and transforming delivery of care through research, education, and innovation. And the organization has been relentless in its journey over the past 20 years to eliminate harm from all patients and staff. And Cincinnati Children's was a founding member of the Solution for Patient Safety Network for all children's hospitals. And I have with me today Pam Vandal, who is the Director of Family Relations for Cincinnati's, and Dr. Stephen Muthing, who is the Senior Advisor for Strategic Partnerships and Advisory Services at Cincinnati's Children's. So Steve, you helped to create that Solution for Patient Safety Learning Network. What does that actually mean? And sounds good, but what did it do? How did you get there? And what do you actually share there?
Sure. So SPS, or Solutions for Patient Safety, I have to say is a great example of a learning health system that's actually described in the PCAST report. And in fact, SPS is actually called out specifically in the PCAST report. So more than 10 years ago, in the state of Ohio, the children's hospitals got together and coached, I have to say, by Paul O'Neill, that we need to learn from other industries. And we saw that no other industry had made significant safety improvement by working independently. It only came through cooperation across the industry. So we decided to stop competing on safety and start working together to eliminate serious harm for both the kids and the staff in children's hospitals. So now SPS is 150 children's hospitals across the US and Canada. And every month, the hospitals share rates of harm, process reliability, best practices, lessons learned. Every month, it's all teach, all learn, including our CEOs and our boards. And so with that approach, we have significantly reduced the rates of harm for kids in the children's hospitals across the United States and Canada. And actually, we post all of our charts on the public website. I'd encourage you to go look at it, not right yet. But let me just share 2 numbers. The rates of decreases in harm that have happened across the United States has resulted in 28,000 less children being seriously harmed in the children's hospitals. Thanks. I'll take that thanks back to all the children's hospitals. That's 28,000 kids today who are in school right this second or at home with their family. And that 28,000 reduction has resulted in $600 million in costs being driven out of the health system. So it's the right thing and it's better value. So you can tell I'm passionate. I could talk about this forever. So if anybody wants to catch me in a break.
Well, thank you, Steve, for getting us started. So real tangible results. And I think one major factor which helped doing this was integrating the patient's voice in a very different way and acknowledging that health inequities actually exist and doing something proactively about it. So Pam, tell us a little bit. You have a pretty significant personal health story as well, but how is the patient voice heard at Cincinnati's?
Thank you so much. I think even by including this as a topic, it shows how important it is for us to always consider the patient and the family voice. So we work at Cincinnati Children's and we have pediatric patients. So often we are talking about our family involvement. It's at the center of everything that we do there. You can see across our system families involved in committees that discuss the prevention of hospital-acquired conditions. You can see them participating in daily family rounds with providers. You can also find them on patient and advisory councils and even quarterly safety roundtables where we discuss several different issues all at one sitting. And truly, the family voice is the hallmark of our system. And I think equity is always a concern. We have so far to go, but I am proud to say that some of my colleagues have worked really hard to take a look at why we don't have a better representation across the system of our patients in these family voices. So we asked specific questions about what is keeping people from participating or speaking up. We found that sometimes it's the easy wins that can get these voices heard. Things like providing childcare or providing transportation. We now also provide stipends for our parent partners because they're working to help make us better, which has been a huge fight. Yeah, we're very proud of that.
So Pam, let me follow up on that. Let's be specific. So when an event has occurred, how does the patient voice get included? How does that work?
Yeah, absolutely. We have patient advocates who work directly with the patients and the families to learn the nuts and bolts of what happened and what the family experienced. And then the patient advocates are able to share that family voice in post-event learnings and move that forward. So we're able to go past the hypothetical and really look at what was it that could have made a difference for that child.
Okay, thank you. Steve, coming back to you, you described this proactive learning system, and you know, we at ACRI believe in the total system safety approach where it takes the leadership, takes the inclusion of the patient, but it takes that proactive learning system. Can you give us some tangible examples on how that actually works? What are some must-haves for the implementation so that the folks here in the room and out there can actually implement it? And they say, yeah, okay, I get that.
In addition to having Pam on your staff?
Well,
yeah, so Marcus, at Cincinnati Children's, we've had sustained significant reductions in harm over the years. And like SPS, we post our results on our public website because it's the right thing to do. I will share in full transparency, please go to our website and look at our results. Not quite yet, don't do that on your phones, but later. But here's two numbers from Cincinnati Children's today. Today is 62 days since our last lost work time injury to a staff member. 62 days, not good enough. Today is 365 days since our last serious safety event for a child at Cincinnati Children's. Thanks, I have to say, sometimes we clap and sometimes we just, that's still not good enough. No. We have work to do. So Marcus, I cannot say all of that's because we partner directly with parents, because we've been on a journey for 20 years. We're continuously trying to learn and improve. But I can say our motto is change the outcome together. And so we deeply believe we would not have made this progress without having the significant partnerships of parents and families all along the way. 3 must-haves I just leave everybody with is you need to have a leader commitment that this is not an initiative, this is a forever journey. This never ends. I think we also have to grapple with the fact that openness and transparency is tough, but it's a precursor for significant improvement in safety. And finally, I'd say we all have to learn every day, both internal as an organization, but also with our peer hospitals. We will go faster together than we will separately. So thanks for including us.
No, thank you. That has been, yeah, thank you. Yeah, we could talk about this for another 3 hours, but we'll have to move on. So thank you very much. And I'm inviting my next 2 panelists, please, to come up. So we heard of the importance of including the patient and creating a psychological, emotionally safe environment to get their input and truly hear their voices. We're going to take it to the next level and talk about how important that same aspect, that culture of safety, the culture of belonging, this culture of emotional, psychological safety is for the staff. And I welcome here with me from MedStar Health, which is the largest healthcare provider in Maryland and Washington, D.C., caring for patients in the community with over 6 million visits per year. A not-for-profit academic healthcare system with 300 care locations, 10 hospitals. MedStar Health is the medical education and clinical partner of Georgetown University and supports a patient-first philosophy that focuses on equitable and safe care, compassion, and clinical excellence. And today, here's Annie Garrissey. She is the clinical lead nurse practitioner, and Dr. Roland Terry Fairbanks, the Chief Quality Safety Officer in MedStar Health. Thank you and welcome.
Thank you.
So let's get right to it. Terry, you have been a pioneer, and you actually started off with human factor engineering. What does that have to do with healthcare? Where those are not machines, those are patients. Why do we need to understand system engineering? What can we learn from other industries, high-risk industry, aviation, nuclear power, military, in applying those systematic approaches? We heard it before, that is crucial. But what can you, from an engineering perspective, tell us? How did you get there?
Well, thanks, and it's great to be here. Human factors engineering is about designing high-risk complex systems that have humans and technology to be high-performing in the setting of how humans work. It's a safety engineering field. And before I became a doctor 25 years ago, I was a safety engineering doing human factors in other industries. So when I came into healthcare, I don't want to be dramatic about this, but I was shocked. Shocked and dismayed is probably not an overstatement. Because what I saw in healthcare is that all of the safety science that was being applied in other industries was unknown to healthcare and not being applied in healthcare. And that's because we don't learn safety science in medical school or nursing school, yet it was doctors and nurses and pharmacists that had become safety leaders. We were not integrating safety science that we needed to with the expertise and rigor that we needed. And we were not doing a proactive approach where we figure out our risks before a patient's injured. We were waiting till a patient's injured and then trying to figure out what happened, and even then we weren't using good approaches. So this has driven everything I've done for the last 25 years. We started the National Center for Human Factors in Healthcare at MedStar Health. MedStar truly wanted to innovate in safety, and Dr. Valdez, I do bring my whole family to MedStar Health. It's the best place to go. So with strong federal support from ARC as a huge partner and other federal partners, we created an innovative space where safety scientists could work along clinicians who understood the operations of safety, bringing in the patient voice, and we tried to create safe systems. And the impact has been profound. We have seen a real difference in the way that we think about safety from the boardroom to the executive suite to the front line, and Annie can reflect on that. But we have to be clear about this. This is really unusual in healthcare, and that is a major part of our problem right now. The US healthcare industry has not embraced safety engineering. We look at ourselves to solve safety problems, and we're not safety experts. So this is a call to action in this, and it's consistent with what the PCAST asked for with federal leadership and evidence-based practice. But healthcare always thinks when we say evidence-based practice, they think we're just thinking about treatment protocols and how you do the best treatment for patients. Evidence-based in safety means understanding the evidence and safety science and applying that, and that takes partnership with people outside of healthcare. This is something we don't learn in medical school, so it's time.
So yeah, I need to move us on, but that is truly fascinating. So we're learning from other industries, but you find it to apply to healthcare. So what do you actually do when there is an unexpected harm event? What does your team do?
Well, like all of the US healthcare, we have not reached zero harm in MedStar Health. As Steve said, we can't clap about that. So when we have an unexpected event, there's 4 things that we do to try to do the right thing every time. First, we expect immediate reporting when there's an unexpected outcome. We don't wait to figure out if there was an error. And that's because we have to immediately establish open and honest communication with the patient and the family so that they understand that they can trust us to make things better. The third thing is we start the learning process early, and we use safety science to do that. And the fourth thing, which Annie will speak to, is care for the caregiver. There's no caregiver that comes to work to be involved in an adverse event. And if we want to create the environment where our caregivers tell us where the risks are so we can be proactive, we have to create the right environment. And we didn't do this right. We've not done it right many times, but in particular, we didn't do it right about 14 years ago, 13 years ago, and Annie was the nurse in this event that we'll talk about. It was an event where we had instituted glucometers, a device, and we had put new ones in. The company had said, how do you want to do all these configurations? We made all these choices. And then at the end of the day, we didn't realize that we didn't make the safest decisions in configuration. Now, we could have used their help in telling us what's safe. They've put this all around the country. But then there was also a device design problem that led to an adverse event. And initially, all the eyes were on Annie when this happened. There was a premature closure on the investigation afterwards where they said this was Annie's fault. Annie was suspended. And because the proper event review wasn't done, we didn't understand what had happened with the glucometer. And then a week later, a second patient was injured. So by closing this event too early, we didn't get safer. And I'm going to let Annie talk about the impact on the safety culture that occurred after that.
Yeah, thank you. And I want to come to you, Amy, but I just want to reiterate on one thing you just mentioned is that once a harm event happens, it's the end point. It's not an individual's fault. Many things along the way have gone wrong, and you just mentioned a number of them. But we tend today still blame the one who is at the end. And any, a harm event, you heard from Dr. Watkins from the patient side, but for the clinician who comes to work to heal, to help, to care, that is a deeply personal event. And I'm so happy you are willing to come here and share that with us. So would you mind telling your story?
Yeah, so after the event happened, all I could think about was the patient. All I could think about was that I harmed someone and they could have possibly died because of something I did. So for days, I didn't eat, I didn't sleep, I was just crying. They called me in and no one could replicate what was seen on the screen. So, in a lot of ways, I felt that I didn't have the support. They disciplined me, suspended me, and did an in-service, and then we moved on. And because they couldn't see what I saw on the screen, it just left me like shattered. I I actually loved nursing. I loved my job. I even volunteered on weekends, my services. It just was like in a snap of a finger, I went from loving my job to dreading my job. I did not want to come to work. When I did come to work, it was lay low. I didn't want to be a resource nurse. I didn't want to help anyone. I didn't want to orient any new students. I wanted to come in, do my job, and go home. It went from me like loving my life to just hating my career. And there was a lot of isolation I felt at the time because, I was in my early 20s. I didn't have, a husband or kids, so like my job was my life. And all the nurses on the floor were my friends. And as soon as this happened, they saw how management was coming down on me, and all of them kind of ducked and covered. No one would take my calls. People that I traveled with and ate with and talked with regularly on the phone just disappeared. When I would come to work, everyone would you could feel everyone kind of looking at you as you walked on the floor. No one would talk to you anymore. It was a bad period in my life.
Yeah.
But the last thing I'll say to that is that we really do need to make changes, because a lot of nurses have come to me as a result of the video, and nurses tell me all the time that they don't report things because they saw how I was treated.
Yeah, and that's the worst thing we can wish for, right? The blame and shame culture, singling out the person who the actual event happened to, and I'm really saying happened to, because as you heard here before, and Terry, help us understand. So what did your team do to rectify what actually had happened?
Well, we did a systems-based event review, and we had to do special simulation to figure out what Annie had seen, because the simulation fluid wasn't even produced for the critical level that she had. We immediately fixed our configuration so it couldn't happen again in any of our hospitals. And then we went to the company, not just the sales reps, but to the design team at the company to make sure they understood what had happened, and they did change it. We created a video. We realized that the effect on culture that occurred afterwards, we needed to make sure every single unit level manager in our organization understood what we meant when we said just culture, and that is we have to finish our event review and understand what happened. Yeah. So we had created a video that Annie was in.
Well, so you mentioned the just culture, which we're going to talk more about in a minute, but so what has changed in the past 10 years? You're back at the job, and you seem to be
Yes,
quite happy.
I'm very grateful to the Human Factors team. Without them, I don't know where I would be. I don't know if I would have advanced in my career. I don't know if I would still be in the healthcare, because, I just really am grateful to them coming and actually finding what really happened. They were able to replicate what happened on the glucometer screen. And, I'm really grateful for the organization that I work for, that they're innovators. They take the time, resources to make systematic changes and break away from the status quo.
Yeah, and unfortunately, Annie's example is not a singular one, right? This happens every single day in our hospitals, in our practices, in our surgery centers, and we just need to move on from that culture and create that emotional and psychological safety for our staff and our patients. Thank you both, and
thank you.
Again, we could talk on this forever. Thank you. So for our last panel, we're gonna talk a little bit more about the systematic approach. For too long in healthcare, we have tried to address issues in silos, and we're gonna fix it alone, and we're going to go after this one thing, we do a root cause analysis, and then we're going to be good. And what you have heard many times today is that we need to take a very, very different approach. And the panelists who just joined me, who are from Prisma Health, and Prisma Health is an 18-hospital clinical integrated non-for-profit health system based in South Carolina. Prisma is the largest private employer in the state and the largest provider of Medicaid services. And Dr. Harper, who is the Vice President of Chief Medical Officer of Acute Care, and Dr. Jonathan Gleason, who is the Executive Vice President and Chief Clinical Officer of Prisma Health, have joined me. And they started a journey about 3 years ago, which was completely different. And when I first heard about it, it was like, wow, that's different. And so, John, how did you arrive there? How did that all get started?
Sure. So as was stated earlier, 2 years ago, we, like everyone else in the world, were coming out of a global pandemic, and we were seeing declines in patient safety and really many of the things that we care very deeply about as a provider organization. And so we did decide to do something pretty radical, which is to completely redesign our clinical operating model. And Marcus, one of the things, if you look outside of healthcare into other very high-performing industries, one of the things that you're going to see is an intense focus, even obsession, on how the work at the front line is designed. Even senior executives in very high-performing industries have detailed knowledge of everything that happens. I'm talking about what happens at 6 a.m., 7 a.m., 8 a.m., 9 a.m. Why? Because it's how they manage risk, it's how they differentiate, it's how they grow their business. It's great business. And in the very best companies, high-performing companies, you'll see that system memorialized in a playbook very, very clearly. And some of those very high-performing companies even brand their system. This is not the way that we typically do things in healthcare. And so, in October of 2022, after 6 months of design, we launched our holistic, simplified, branded set of workflows, systems, and our playbook, and we called it our clinical operating system. A couple of details around this is that it really defines how team members interact with each other and how they interact with patients, and how all of that is supported seamlessly with technology throughout specific times of the day. It's all orchestrated. It also provides radical transparency to really important data points to everyone in the organization. Environmental services worker to the CEO. Everyone sees it at all time, real time. Everyone is an owner. The third thing I would add is that it really, there is a structured coaching program that's a critical component of it. We are actively always coaching our team members. It's actually happening right now while we're sitting here, coaching all of our team members and how to perform in the operating system, and it creates a very clear pathway for team members and patients both to escalate issues all the way to the highest level of the organization. They know it will get resolved. So we're a couple of years in, as you've mentioned, and at this point, we've had about a 30% reduction in serious safety events. And I'll also, to your point, we're not where we want to be. It is an obsession, has to be. And I will underscore what the Undersecretary of the VA said, which is that we've seen more than a 40% increase in reporting with a 30% reduction in serious safety events. That's what safe looks like. We've also done our safety culture survey, and our safety culture in our organization is now more than 20 percentage points above the national average. So not 20%, but 20 percentage points above the national average.
You've even given it a name, right?
We call it Pulse because it really is the cadence and the rhythm of the organization. And so, importantly, we've also built trust with our patients, our team members. Our patient engagement results are now among the best in the country. Our team engagement results are significantly improved and better than benchmarks. Our turnover rates are down, and we've had a reduction in length of stay, so we've gotten more efficient. That has resulted in improved financial performance, which is so important for the largest Medicaid provider in South Carolina, right? And so, it is better business to be truly an operating company where there's an obsession with the design of the work, even at the front line. I believe it's the future.
I think we just have to acknowledge we're not just delivering care. We're running a large, complex operation. And so, Greta, I want to talk to you. You've been around the block for a little bit, more than 3 decades, serving the community. Wasn't Prisma then, but the same communities over the past 30-plus years. And from your perspective, John talks a good game, but what did that mean? And I mean this as a compliment, by the way, John. So, but what did it mean for you as a clinician to be involved in this and seeing these changes? What did it mean for you?
Yeah, so as you referenced, I've been around the organization for almost 35 years, and this was different, very different than anything that we had ever experienced or attempted to do in the past. This pulse, that we call it, is required a complete redesign, and it is an entire operating system. So it's really, really different from that standpoint. Dr. Gleason actually arrived during the pandemic, and like many other health systems, we were experiencing significant clinical challenges and also workforce and economic turmoil. Despite that, and despite all the challenges that we were confronting every day, Dr. Gleason shared a very clear vision for this new operating system and the plan as well. And along the way, he brought leaders like myself along, all of the leaders, in terms of what we could expect, and then also, very importantly, how we could help inform, build, and then, as leaders, implement our new clinical operating system utilizing the playbook. We say at Prisma Health that having an elite culture is important and but not sufficient. We also say that having an elite system is important and not sufficient. It really takes both. I'm the executive sponsor for Just Culture, and as you know, Just Culture is a very important foundational construct for a safety management system, and it's a part of Pulse. As such, it's all about learning, improving, and then shared accountability as well. Our performance has increased and our culture has been enhanced. A quick example of that is that at our baseline, before we implemented our new clinical operating system, anonymous reporting was over 50%. Team members did not want to share their name. 1 year into Pulse, that number dropped dramatically to just 13%, just 13%. We felt it was really, really important to implement our system before implementing our culture. We trained over our almost 30,000 team members. You know, that's our workforce at Prisma Health. But we said, first things first, let's get the system in place. That can be a little counterintuitive, but the rationale is that we want team members to report, and then we need to have a system that is capable of translating the issues into solutions, into change. So that has worked well for us, and I'll leave you with reshaping our system, reshaping our culture required reshaping our system first.
Thank you, Greta, and I'll come back to you in a minute. But John, I think Greta mentioned something important, which is she said you brought them along. How did you do that? How did you get buy-in from the organization? We in healthcare, you know, physicians in particular, are not like others to tell us what to do, usually. And so how did you do it? And what was the impact it had on safety and on equity? Because I think that's as important as we mentioned before. We won't get to better patient safety if we don't address inequities.
Yeah, so I'll start by saying, you know, this approach is very deeply informed by my experience in working outside of healthcare in a global business services company and how they do work. So that's really, really important. And having done this now several times in large health systems helps when you're trying to bring people along, because I know how this is going to work. But one of the really, really important things, Marcus, is that it's been mentioned several times today, healthcare workers are pretty awesome people. They're pretty amazing people. These are people that care deeply about their patients. They have missed birthday parties and holidays to gain the skills to take care of patients. And they're really not fundamentally the problem. And I as an executive, and we as executives in the company, we say that. We say not only is the system the problem, it is my problem, and with your help, we will fix it. And that rings true, right, to people who work in healthcare, and it's also comforting to them, right? It gives them a sense of hope, and so they're sort of automatically on board. I'd say getting big wins early is important. One of our big wins early was changing all of our sepsis care pathways, and we reduced our sepsis observed mortality rate by about 30%. That gets a lot of people's, you know, attention and gets people to say, hey, you know, this feels real. Let's get on board.
And you wanted to mention real quick the equity, what it did do.
Sure. So yeah, thank you. I want to give. There's been a lot of discussion about bringing the voice of the patient into this, and we do that systematically, right? And so, one incredibly vulnerable population is people with intellectual disability that have incredibly poor health outcomes. The intersectionality of disability and other social determinants of health outcomes is a place of very poor health outcomes. So our Patient and Family Advisory Council for Intellectual Disability and our team members told us that when patients with intellectual disability were being discharged from our hospital, they always needed a higher level of care coordination, right? And we needed to not rely on the team member to be able to remember that. We needed to build it into our system. It had to be hardwired. And so we built that into our system. So it's just another illustration of the main point, which is that we have to build equity into our systems, we have to build safety into our systems, and that only really works if you have that holistic design moment for the entire operation of the organization.
I could talk about this, I was about getting the wrap it up sign.
So could I. Yeah.
But I want to leave you, Greta, with the last word. So we learned that you're going to retire after a distinguished career of 35 years. First of all, I want to thank you for more than 3 decades of taking care of patients. But where's your head at? Are you seeing hope? Did we crack open the door to solve the problem? What do you think?
Well, I really do believe that we can, as a nation, improve the state of health for all. And an important part of that is sharing our success with everybody. So I'm really grateful to be in a room with all of you to enjoy this experience today. I read that President Biden talked about making the impossible possible as related to PCAS. That really resonates with me when I think about what we're doing at Prisma Health and the success that we've had with our new clinical operating system, which leads to improved quality, safety, efficiency, equity, and sustainability, particularly when I look at the troubled state of our healthcare systems throughout the nation. So this really represents an opportunity for us to all go down the same path if we're willing, and that makes me very hopeful. I'm also optimistic about who we are as healthcare providers and what we can do as well because of the successes that we've heard about, and particularly our success, which I know a lot about, which gives me hope for a much brighter future. And at the end of the day, I really do think that as a group of healthcare providers, if we're willing to collaborate and borrow from each other and go down the path together, knowing that if we utilize the clinical operating system that brings it all together on a daily basis, that we can make the impossible possible in healthcare. And at the end of the day, I go back to my roots as a provider. That is what our patients deserve.
I sure do. So thank you very much for listening. I think you saw that by not doing the same thing over and over again, which clearly is the definition of insanity, we can actually make a difference. And so if we take a systematic approach, if we include human factors, if we learn from other high critical industries, if you apply a just culture and include your workforce safety and the patient voice in your journey, we can, and we must make a difference. So thank you very much, and Jade, back to you.
A very grateful thank you to Dr. Schabacher and all 6 of our panelists for sharing insights about how they've been able to make healthcare, the healthcare delivery system safer. It is my greatest hope that what we learn here today will serve to launch a larger national discussion about how we think about system redesign. I would like to invite Dr. Sim and her panel to the stage. Dr. Sim serves as the Director, Clinical Quality Management, Medical Quality Assurance, Ethics, Graduate Medical Education Policy in the Office of the Assistant Secretary of Defense for Health. If that were not enough, she also serves as the Office of Assistant Secretary, also the Assistant Director, Transformative Medicine and Health Innovation here in the Office of Science and Technology Policy. Dr. Sim?
Thank you so. Oh, okay. Thank you so much, everyone. Thank you for being here. Good morning again. We have such a distinguished panel today. Today we're going to be talking about safe care everywhere. And so what we're looking at is highlighting the extraordinary work across the private sector and across different settings in healthcare as well as different populations. We want to share the exciting work that's being done and the power that's in our safety community. So very much also want to leave here with some practical ways and interventions that have been proven by our guests here to work in the different settings. So I want to introduce our panelists. We have in the middle Ms. Ronnie Snyder. She is the Vice President for Program at the John A. Hartford Foundation. At the end here, we have Dr. Karen Feinstein, who is the Chief Executive Officer of the Pittsburgh Regional Health Initiative. And then right here on my left, we've got Kieran Staunton, who is the End Sepsis co-founder. And while not on our panel, I do want to acknowledge, because not only is he the co-founder, he is Rory's father. And Rory's mother, Orlaith, and his sister, Kathleen, are here. So thank you so much for being here. So we'll start with Kieran. We know that the mission of End Sepsis is deeply personal for you. Tell us how you came about this work and to lead it, and tell us about Rory. And if you'd like, we'd love to hear about Rory's regulations.
Thank you, Dr. Twee. Thank you, first of all, for Jade for putting this on, and a big hand for Jade. She deserves it continuously. And thank you, Jade, for bringing sepsis to the White House. We've been trying since Rory died for 12 years. Our 12-year-old son, Rory Staunton, cut himself playing basketball, got a small cut on his arm. The gym teacher put a Band-Aid on it, didn't send him to the nurse. That night he was thrown up. The next night we had him at his pediatrician. She sent him to the hospital. The hospital ran some checks, sent him home. The following night, he was back in the hospital where blue spots were coming over him. 2 days later, he was dead. Rory Staunton was 5'9". He was 165 pounds. We now realize that he was a flashing red light for sepsis all along, and that no one in that hospital ever looked for sepsis. The hospital our pediatrician sent him to had no sepsis protocols on the floor. But up the street, the hospital where Rory was born in Northwell Hospital had sepsis protocols in place. So had he been sent to the hospital he was born in, he'd be alive today. But because he was sent to the hospital down the street, he's dead. We never heard the word sepsis until Rory was dead, probably 2 days. So, then we went online looking. We found out that there was very little online, first of all, but that sepsis was killing 270,000 Americans a year in 2012. We went on CDC's A to Z, and under the letter S, there was nothing for the word sepsis. We got a meeting in the CDC building in Atlanta through our good friend Senator Schumer. We met with the CDC director. And while we were in that building that day, they handed us out some paperwork to read. And she said, "We have nothing here on sepsis." There was nothing in the building. The only paperwork on the building on sepsis was this brochure that my wife brought in with her. In the CDC building, then when 270,000 Americans were dying. We now know that sepsis deaths are preventable. Rory's death was preventable, and many, many thousands of 350,000 Americans today die from sepsis. While we were in this building this morning, nearly 300 Americans died from sepsis. Preventable deaths. If there was a killer out there killing 300 people a morning, there'd be someone doing something about it. We also know that the antibiotics, IV fluids, and our son will be alive. We're not waiting for a cure for sepsis. We're waiting for leadership. I shouldn't be looking over at the executive office when I say leadership, but I am. Very few hospitals had protocols, but yet we went to Northwell Health and Long Island. They cut sepsis fatalities by 50% in 5 years. So when someone used the expression earlier, sobering facts. It's the sobering fact that we as parents, Orla and I, not alone was there no one doing anything about it, but we were challenged in setting up a foundation to educate Americans and to see to it that something could be done, that people wouldn't be buying coffins. Is there anyone here who has buried their child? Welcome to the club, unfortunately. Unfortunately, the club no one wants to join. So when we say it's not a statistic, we bought a coffin. That is what the problem is. So then we found out that, well, what was happening in Northwell could be done in other hospitals. We went to see New York Commissioner Shah, I don't know if he's here or not, and Governor Cuomo. And they said, no, this is too important for legislation. We're going to enact a regulation. It's going to be evidence-based protocols for the identification and rapid treatment of sepsis. Now, Rory's regulations are exactly the intervention data, the intervention that PCAST show must be adopted. PCAST has said, get Rory's regulations into your area, and that'll save lives. Now, in the first 4 years of Rory's regulations in New York, independent data showed we saved 16,000 New Yorkers. That was Orla, I, Kathleen, and a budget of less than $1 million a year. What we did was we tried to take that coast to coast. In many states we went into, there was a strong lobby against us, saying, let be what is, but we didn't give up. Because when you tell an Irishman you cannot do it, or an Irishwoman you cannot do it, that's the wrong thing to say. We have, Rory's regulations of sorts are now in 5 states, covering 50 million Americans. And just last week, we had sepsis law introduced in the United States Senate by Senators Schumer, Collins, and Casey, and that's going all the way. Now, and what that is doing is that from coast to coast, there shouldn't be the question, if you're driving down the road with your child at 10 o'clock at night, you shouldn't have to wonder if the hospital on the left has sepsis protocols or the hospital on the right to save your child. Because it doesn't happen with stroke or heart attack. It shouldn't be the toss of the coin which hospital you go to. It should be done. So what we are saying, and I'll cut it up at this, is we have got everyone rowing in the one direction. American Hospital Association, the CDC, ourselves, and all the groups are behind us. Now, all we need is everyone come on board and everyone push. And before I go, I'm just going to say something. This is what we had to deliver to every member of Congress, to every senator. My daughter Kathleen has them there, and I want to make sure everyone brings one home with them or brings one to their hospital, because I'm going to tell you something. This is the startling reality of what sepsis is doing to our loved ones. Thank you.
Thank you so much, Karen. So we're going to turn to Ronnie. You've been doing this work for a while. And what do you think is the biggest challenge for patient and workforce safety? And how does that fit into the mission of your organization, specifically age-friendly healthcare systems?
Thanks so much. So first, really do want to thank people for bringing personal stories that are so meaningful. Dr. Watkins, Annie, and also Rory's story. I think this really gives life to the very important issues of safety. Our mission at the John A. Hartford Foundation is to improve the care of older adults. And the biggest patient safety challenges we see are related to demography, of course, the growing number of older people in our communities, complexity for older adults, and disproportionate harm. It will not be a surprise to many of the folks in the room that older adults are the greatest utilizers of healthcare, and that number is only going to grow. They have more in terms of number and also more complex conditions, and they experience more harm from healthcare than any other age group. We have the opportunity, this wonderful opportunity, to overcome many of those challenges and improve safety for older people through what are known as the 4 M's and age-friendly care. And the age-friendly healthcare movement itself, which we call on all health providers, all health systems to join. Right now, there are over 4,000 age-friendly health system sites of care. They include hospitals, ambulatory practices, nursing homes, and convenient care clinics that are all part of this movement. The movement is led by the Institute for Healthcare Improvement, together with the American Hospital Association and our foundation, the John A. Hartford Foundation, all of whom are champions of safety ourselves. And everybody here should be encouraging your health systems to join as well if you are not already. So let me describe a little bit about what those 4 M's are, because they point us to the greatest sources of harm and also the best opportunities to improve patient safety for older adults. So first, harm comes from care that's not aligned with our goals. So here's an example of that. 20% of older adults undergo surgery in the last year of their lives. Frequently, that is unnecessary surgery, and nobody, not one of us ever, wants unnecessary care. We call that what matters. That's the first M, what matters. Second, adverse drug events due to polypharmacy or inappropriate medications specifically for older adults are a huge source of harm that affects 20 to 30% of older adults. That's medications, the second M. Delirium is another really common source of harm that affects more than 7 million hospitalized Americans per year, many of whom, the disproportionate number of whom, are also older adults. And that's frightening for the patients themselves. It's very frightening for their families. It's confusing. And lots of people in those situations lose function during their hospital stays because they're not mobilized, resulting in far too many falls. These are the last 2 M's, mind, which is anything cognitive, dementia, delirium, depression, and mobility. So it's important to note that the age-friendly health system's care and movement is actually best care for everyone. It's just so much more important for older people who frequently have multiple and or complex chronic conditions. And so we really need to pay attention to this bundle of those 4 M's together. By reliably providing evidence-based approaches for each of the 4 M's, and by always focusing on that what matters, keeping that at the top of mind to the older patient, we have the ability to overcome ageist and other biases. And I just want to note that for those of us who care deeply about equity, ageism magnifies a lifetime of inequities. We all hold certain ageist views, and this particular movement, this particular framework is designed to call those out and systematically, to a point that Bob Valdez made earlier, systematically address that care. Twee, I know you're going to ask about some results, and we've got lots of amazing results. At this point in time, it's a fairly new movement. Most of the results are site-based in individual places. We've got, a hospital in California where, due to 4 M's care, once it was implemented, they had an 11% decrease in stay and a 41% decrease in getting to surgery time. Which led to a cost savings of $300,000. These are safety issues that also affect the bottom line, something that health systems care deeply about. another hospital in California where readmissions are down, another in Chicago where patient satisfaction was raised to above national averages after the implementation of 4M's care. In addition, there are many other sites of care. So take a nursing home, for example, where both dementia and depression screens were implemented following 4M's implementation. And that led to that, together with physical therapy and together with some exercise programs, led to a decrease in antipsychotic drugs from 20% down to 5%. Similarly, we have these kinds of evidence, these kinds of outcomes, rather, in clinics, ambulatory clinics. We've got one in Oregon that showed that after some falls screenings and then the follow-up falls programs, they were able to decrease subsequent hospitalizations for falls in their community. So there are a number of tools that organizations can use to get to age-friendly health systems and the kinds of interventions that are useful. There are validated screens, there are evidence-based interventions, checklists and guides. But the real thing that I want to note is that all clinicians and all health systems can join the age-friendly health systems movement through a 7-month, it's a coaching and support plan. We call it an action community put on by either the Institute for Healthcare Improvement or the American Hospital Association. There's one starting this month, and any organization can join. It's free to those organizations that are interested. It's not free, we pay for it. But we really, our mission is to improve care for every older adult, everywhere they go, in every site of care. So there are additional programs as well that speak to that kind of quality improvement and safety improvement for older adults. Specific to hospitals, there is a geriatric surgery verification program. There is a geriatric emergency department accreditation, and we're currently working with ARC and others in some emerging work around diagnostic excellence that's specific to older adults, and creating also a number of different tools and resources in that field.
Great, thank you so much, Ronnie. Well, since actually you both have already not only told us about your missions, but also tools and really actionable things that folks can do here today. I'm going to turn finally to Karen. And Karen, what do you think is the biggest challenge? You've heard from both of our other panelists here. What do you think is the biggest challenge, and what are some ways to address it? I'd also ask if time permitting, if you've got it, with all this focus that everyone has had on innovation and the use of technology and tools, what do you see as areas of low-hanging fruit where we can make an impact with leveraging technology?
Thanks, Twee. Well, one of the biggest challenges and one of the things most of us in this room, or we wouldn't be here, do not acknowledge is that harm is an inevitable byproduct of healthcare. And, it's just sort of the cost of doing business. So we wouldn't be here if we believed in that. I think that's a challenge. And also, as we've heard from other speakers, our tendency to look inward, only look inward and not engage outside of the health professions. So we looked at other industries. What could we learn from other industries? Paul O'Neill and I started the Pittsburgh Regional Health Initiative 27 years ago, and we tried a number of interventions. They sounded really promising, and they weren't. And I do worry we keep hanging on to them, but there are so many things on the horizon. So we decided to have a whole day of hearings with our tech council, and we heard from manufacturing, energy, transportation, organized labor, and the military. What are you doing that's producing great results that we're not? The number one thing we learned, and we heard it from 3 of the systems here today, is a fundamental total commitment to safety as the platform for doing business, morally, financially, practically. And from that stems everything else. First of all, data. We haven't talked much about that, but we really need real-time, undoctored, honest data in which to improve. Secondly, ongoing research and discovery and innovation. There's so much happening, and particularly when you introduce the world of technology. With AI and ML and robotics and advanced analytics, there's so much we could be doing. And once you make that fundamental commitment, you start investing in that. And people will commercialize discoveries and someone will buy them because of their fundamental commitment to safety. So the other thing that if you're going to keep introducing interventions that have been proven and other discoveries, technology that's been proven, it's ongoing training and ongoing training, as we heard from other hospital systems, that you can't expect everyone to use new interventions and use new technology correctly if there's an ongoing testing and training. So we're optimists. We think there's a whole new world if you will open yourself to other interventions and other paths we haven't done yet. And we do thank PCAST and the PCAST work group. Thank you so much for opening our ideas. So I'm just going to borrow from your playbook a National Patient Safety Board, or safety team, as the report said. As we all know, this isn't a brand new idea, right? It's been around for decades. It keeps coming up and never happening, but a place where research and discovery is constantly taking place. One home, and one home that is engaging many other disciplines. With all respect to medicine and the health professions, there's so much we all know we can learn from engineering and the many aspects of technology. So thank you, PCAST, for reiterating, and thank you, the Anesthesia Patient Safety Foundation, for proving since 1985 that you can have a 20-fold improvement in safety just by doing this. Secondly, we loved the idea that there were a lot of innovators doing hackathons, business school competitions, startup competitions, in all these startup communities and innovation hubs. So we said, what if we gave an award to existing competitions for the best idea in patient safety tech? Will anyone take us up? And the first two takers were MIT and South by Southwest. We said, terrific, we're off. We now have 727 teams in the US, Canada, and England who've competed. We're very excited, and we're about to have a grand challenge on the stage at the Consumer Electronics Show in January among the winner of the winners. So that's just, there's so much interest in this. And by the way, these are business school students, architecture students, engineering students. These aren't just students in the health professions. We also did a documentary. I've heard from some of you, you've seen the pitch. It's highly optimistic. We absolutely love it. It follows one of the winners of the patient safety technology competition and his journey. He graduated from Brown, and he now has a discovery to improve the outcomes of pregnancy, and including sepsis. He now is it's worth, I think, $18 million. He's the graduate of one of our universities. But there's so much energy and interest in this field. We want to keep building that pipeline. And the movie's really good. It also features a whole host of innovations that are so upbeat. And the one thing some of us were talking about, we keep saying, how long is it going to take before these proven interventions become standard practice? Yes. And thank you, we've heard that on this panel.
Thank you. Yes.
And the last thing, the last two things. One is we're waiting and waiting to have the PCAST work group recommendations solidified. Thank you, Joe and Eric,
thank
and
you,
everyone else.
I'm sorry, I think we have to move on, but I just wanted to say thank you to all our panelists. Greatly appreciate. So what I heard is Innovation Challenge, 4 M's, and always remember Rory, and thank you for his regulations. Thank you so much, everyone, and just one last quick thought from each of you. If you wanted to say, this is the charge, this is the thing you should do when you go out of here, here's the one thing you can do today, what would that be?
Dr. Tree, before I go to that, let me just say that African-American women are 2.5 times more likely to die from maternal sepsis. Isn't that some frightening stat to walk out of here with? Anyway, I think everyone should walk out of here ensuring that no patient dies from sepsis.
I think everyone needs to ask their health system to become involved. And I want to suggest that you ask your hospital if they're prepared for the new age-friendly hospital quality measure that CMS approved that will start January 1st, where we're going to see, it's a huge signal to the world about how important this care for older adults is. Soon almost all hospitals will be reporting on whether they have protocols in place to address the 4Ms.
Great. Thank you, CMS.
Thank you, Dr.
Well, I would love to have everyone join the National Patient Safety Board Coalition. You can find us online. I'd like to have the PCAST recommendations move forward. And I also would say to everyone, sometimes in healthcare we have a fear of technology, and we spend a lot of time being skeptical and pointing out how dangerous it could be. But I'd say we should open our minds to the possibility of AI and other technologies to actually enable our staff at the front line to provide safe care.
Absolutely. Thank you so much.
Thank you.
Thank you, Dr. Sim, and to each of our panelists for sharing your life's work with us. It really does take each and every one of us to make meaningful and sustainable change in our safety outcomes. Finally, I would like to welcome the President's Council of Advisors on Science and Technology, Patient Safety Working Group co-chairs, Mr. Joe Kiani, Chairman and CEO of Masimo, and Mr. Eric Horowitz, Chief Scientific Officer at Microsoft.
Thank you so much. What happened to Dr. Watkins shouldn't happen to anybody, especially a black woman. Black people have 3 times the chance of developing cloth, 3 times the chances of getting VTE and pulmonary embolism. So you think people would look for your signs, like when the blood fell, the clots fell, to all of the things you went through the next few months. I'm so sorry for what you've gone through. And Rory, my God, you know, horrible that he's not with us. His high heart rate at his size, his high white blood cell count, should have told people this could be sepsis, not just the stomach flu. Look, medical errors, if there were something that there wasn't preventable evidence-based practices for, may be understandable. But they're not when we have things like failure to rescue, things like blood clots you could detect and deal with, things like medication error, opioid overdose. There is evidence-based practices that can help get rid of these problems, yet they're not common practices. I'm so grateful to my colleague Eric Horowitz and I, who worked so hard to put this PCAST report together. We had a wonderful group of people like Dr. Peter Pronovost, Dr. Don Berwick, Sue Sheridan, Julie Morath, helping with the other names, Harlan Comos, and the gentleman from the aviation safety, Chris Hart. Thank you, thank you. 2 years of effort, it's out. Look, we're all here because we wouldn't give up hope. We wouldn't stop working hard. We knew medical errors isn't just part of the program. And I'm so heartened. I'm so thankful, Jade, Danielle. I'm so thankful to the President Biden administration for making today happen, for giving us this big milestone that we needed. Seeing what is being done by AHRQ, CMS tracking the top errors, and hopefully coming up with evidence-based practices for them. It really makes us feel great. And before I give my colleague Eric a chance to speak to you, I ask you all, those watching, those here, please, for the next year, save one life. You ask how? Implement the evidence-based practices. Report your harm and errors publicly because we can learn from them. And last but not least, share your data. For companies like mine, share your data. You know, if that data was shared years ago, then there would have been AI-based systems that would have predicted what's about to happen to Rory. So thank you all. Thanks for doing what you've done. Eric, thank you.
Well, thank you, Joe. I've enjoyed working with you on PCAST, and it's really been inspiring to hear the stories today at the Healthcare Safety Forum on this important occasion, World Patient Safety Day. The stories, the experiences, the sparks of new directions, aspirations, measures, programs, and processes have been really interesting. Special thanks to Jade and Danielle, everyone at the White House and across sectors working on healthcare safety. And many of you hopefully will be building on the recommendations of the PCAST study. I'd like to express, as Joe did, my deep appreciation for the PCAST study group and the support team, including Twee, who just was moderating the panel. The study benefited from the participation of remarkable experts who have devoted their lives to healthcare safety. Joe and I are also very grateful to the leaders at the federal agencies who shared their time and expertise in many calls and consultations, and great passion we saw at HHS, including AHRQ, CMS, CDC, FDA, OIG, and at the DoD and Veterans Affairs, all deeply inspiring. Needless to say, we've all been impressed by the energy, passion, and creativity of individuals and nonprofit leaders in patient safety, some of whom have been personally touched by the very issues that we're trying to solve. Hard to forget any of those stories, of course, and the people influenced in those situations. The tireless work of these folks, a number of whom are in the room, to prevent the tragedies they've experienced from befalling others is inspirational. So despite progress, healthcare safety remains an urgent issue, and without focused and coordinated actions beyond the sparks we've been hearing about, the problems will persist. But I'd end today by reiterating some of the findings in the PCAST report. There's been improvement over decades, but the statistics are still alarming. 1 in 4 hospitalized Medicare patients experience an adverse outcome. 1/4 to 1/2 of these could have been prevented per expert analysis. Clearly, many of these events cause unnecessary pain and morbidity, extended hospital stays, but a significant number, we have statistics, result in severe or catastrophic harm. This year's theme for World Patient Safety Day is misdiagnosis. This is a major area of opportunity. As highlighted in our PCAST report, misdiagnosis leads to 500,000 Americans suffering permanent disability or death each year. Is it really a hard problem? Yes, but it turns out 5 diseases could be focused on that make up or account for 40% of these outcomes: stroke, sepsis, venous thromboembolism, lung cancer, and pneumonia. Several reports have said, let's start by focusing on these 5 disease entities. Human toll is staggering, but the financial cost also runs into the hundreds of millions of dollars. So the PCAST study outlines several key paths forward. We found that current incentive programs do not address the majority of harms that patients experience. We need to update incentives to address the adverse outcomes we wish to avoid. We need better systems for tracking and reporting adverse events. And as mentioned several times today, we can harness computing technologies, including really making use of electronic health records and new kinds of sensing and advances in AI to provide early warning of errors and risks. This is an area that I've done a whole bunch of work in, and I see the promise. These systems can bolster diagnostic accuracy and care management and reduce the number of poor outcomes. Medicine is complicated. Physicians are very busy. Errors are to be expected. We can use technology to augment cognition. We need to address the sociology, psychology, and human factors of healthcare to strengthen safety cultures in hospitals. And finally, as has been pointed out, we're humble. We don't know exactly what to do and how well our recommendations will work. We need a continual learning program with feedback, R&D, to understand if our recommendations will have impact. The challenges ahead are significant. We don't have to tackle all of them all at once. You know, listening to today's talks and seeing all of you, it gave me lots of hope that we can take focused steps forward. And let me end with one of my favorite quotes of Mark Twain. He said, "The secret of getting ahead is getting started. And the secret of getting started is breaking complex, overwhelming tasks into small, manageable tasks." And so with each step, we move closer to a safer healthcare system for all Americans. Moving ahead, I encourage everyone to connect with the National Action Alliance for Patient and Workforce Safety, led by AHRQ, on behalf of HHS. And I want to thank you all for coming today and your commitment to take steps forward. The stakes are high, but I believe, and Joe believes, and the PCAST committee believes, and so many of you believes, so much can be done. Thank you so much. Jade.
Thank you. Thank you, Mr. Kiani and Mr. Horvitz, for that call to action. And on behalf of the Office of Science and Technology Policy, Executive Office of the President, I would like to extend our gratitude for participating in the White House Healthcare Safety Forum. This concludes our program for today, but begins the work of the National Action Alliance for Patient and Workforce Safety. So thank you all for coming.